We understand what the food is going into the room. We understand what was consumed by food product and can dramatically improve the insulin dose required for that particular patient. We know that the outcomes of managing those glucose levels to very tight levels is incredibly important, and the outcomes are significantly better. Imagine for a second a physician in Delhi, India, develops treatment for esophageal cancer, which improves the chance of survival by 6 times. This physician, she understands the drug protocols, she understands the radiation therapies, she understands the food consumption, all the things that would be involved in a detailed protocol for esophageal cancer. Now imagine for a second it's your son, shows up in a hospital in Salt Lake City, Utah, with the exact same diagnosis. How important would it be to you and your son that that knowledge created in Delhi, India, was able to make its way to Salt Lake City, Utah? 6 times better chance of survival of this deadly disease. This happens over and over and over again around the world. There is expertise being developed, there is knowledge being created, and there's not a good way to share that knowledge. Best case would be a journal article would get written, and by chance, the physician in Utah would have read that journal article. This is the sin I was talking, the crime I was talking about, Sanjita, earlier, that this knowledge exists. We can save lives, we can do it at a cheaper rate, but we don't have the vehicle to exchange that information. That brings me to data standards. Why data standards? Because that's how knowledge moves. If data standards don't exist, you cannot move this knowledge around. Real success is not achieving greatness. Rather, real success is greatness that achieves or does something for the many. It's when all ships arise. That is a true success. Let me talk to you for a second about rail gauges in Australia. In the early 1900s, to go from one side of Australia to the other, you would have to get off the train and get back on a train 6 times. Why? Because they had different gauges of train. The train simply couldn't go any further. You had to get off the train and get on one that would actually fit on the gauge that you were going on. So they came up with great ideas, great technology that will allow them to use the gauge of rail that was there. So in this picture, you're seeing a train that's been driven on top of another train so that it could move through a section where the rail gauges has changed. Really good technology, really interesting engineering, probably not very effective, and I'm sure there were some accidents along the way. This picture is a coal car that's been pulled up, and this huge contraption device lifts up the rail car, dumps the coal out of the one car into the other, so that, again, it can move it across the country. Now, these are actual examples of rail gauge problems that happened in Australia. Imagine the expense of building the device. Imagine the danger associated with shifting the cargo and the overall cost. Now, I don't know how many of you are involved with health information exchange, but that's exactly what I think it looks like. We develop huge, expensive devices that allow us to move data from one system to another, and I've heard people all day today talk about this issue, this exact issue of the inability to move data between systems. This is our health data standardization problem today. This is a neonatal ICU unit, and there's a baby in there. And those devices are all giving care to that child. Now imagine that you're the physician that walks into this situation and needs to make the correct diagnosis or make the correct procedure or prescription or whatever needs to be done. How do you do that? The human mind can take 7 items and put it into its brain and come up with a consistent, correct answer. There are way more than 7 items that need to be understood here. And in fact, the average clinical decision requires 42 data items. And we expect clinicians to do that without assistance. It isn't going to happen. Let me go back to the railway system just for a second. In Australia, in the early 1800s, the Earl Grey, not the tea, but the actual Earl Grey, went to Australia and said, we need to come up with a standard gauge of rail across the country. It took them well over 100 years to implement that change. But what courage did the Earl Grey have to go to that country and demand that they come up with a standard rail gauge so that they wouldn't have to build these kind of devices and have these problems. In healthcare, we don't have train tracks. But in healthcare, we have the requirement for standards. To create a new paradigm for healthcare that actually allows for knowledge to be shared, we need to have standards, standards in terminology. Sanjita talked about that earlier today. We need to have standards around clinical data and how it's structured. And the clinical element model exists. HL7 has something called CIMI, C-I-M-I, which is a standard that's being adopted around the world. The Health Data Dictionary from 3M is also an open source, now terminology that I think we can adopt around the world. With this, decision support or real knowledge can be shared around the world that would allow your son to have the knowledge created by that physician in Delhi and have a 6 times better chance of survival. To raise new questions, new possibilities, to regard old problems from a new angle requires creative imagination and marks real advances in science. Innovation is important. To me, innovation is the blood that allows us to achieve more, to do more for the population and the people that we are trying to serve. The Earl Grey had tremendous courage, had tremendous foresight to ask the country Australia to come with a single gauge of railroad. My question to you is, who's going to be the Earl Grey in India? Who's going to be the Earl Grey in the United States that has the foresight and the fortitude to ask for the right things to be done? It'll be hard, but it'll make a huge benefit for healthcare around the world. Thank you.
Thank you, Mark. Now moving to our next speaker. Antoinette Gadam is the telehealth coordinator and senior advisor for McGill University's Integrated Healthcare Network in Quebec, Canada. She'll be addressing us on the virtual health and social services sector, a method to transforming healthcare delivery, describing successes, challenges, and incentives for compliance. Her diverse professional experience includes nursing in intensive care, cardiac surgery, and as a nursing manager of a long-term care unit. Ms. Gadam worked in setting up medical, social networks in the response to the needs of children with chronic diseases in Lebanon. For many years, she has coordinated a joint research project involving the University of Montreal and McGill University, and has co-authored 2 publications. Please welcome me in welcoming Antoinette Gadam. Thank you.
Namaste, Assalamu alaikum. I hope I did it right. That's 2 words I learned from the taxi driver who drove me yesterday through the city. So if I pronounce it not well, excuse me for that. First of all, I'm very honored to be here today, and I want to thank the organizing committee and Professor Ganapati especially to give us the opportunity to share with you today the Virtual Health and Social Service Center that I'm going to represent. That's the experience of Ruiz McGill in telehealth, a project that was funded by the government of Quebec and InfoWay Canada, and we were implementing this project since January 2010. We hope that we'll finish implementation in January 2013. So we are at the end of the implementation. I will start my presentation by give you the rationale behind this project, the vision that the Ruiz McGill has, and the deployment phases that we have done until now. My objective, as I said, is to share with you this experience, and I agree with the previous speaker that we have learned a lot from you today, and we believe at the Ruiz McGill that the need is the basis of development of telehealth. Where is need, the telehealth is increasing tremendously. I have, okay. So in 1994, the government of Quebec reformed the health sector and divided the territory of Quebec in 4 networks. What you see on the map in red is the Ruiz Health Network that I'm representing today. It represents 62% of the geography of Quebec with 1.7 million of population. It's almost the seventh of the population of Quebec. If you compare with Andhra Pradesh, you can have a sense of the comparison between the two countries. We have a huge territory with low density of population, isolated and rural region, with lack of accessibility to specialized care, and even the first line is very deficient over the 52 parallel at North Quebec. We have the second line completely absent, so people to have access to care has to travel like 2,000 or 3,000 kilometers south to have access to this care. I'll give you an example of a village in Nunavik who has population 500 population with 3 nurses, no general doctor, no specialist going to the area. So in this country, this village is not even accessible by road. People have to travel by plane, and even in the winter, it's not accessible by plane. So it gives you an idea about the problem of accessibility, and even the professionals in this country are isolated. When facing complex problem, the frustration gets higher, and it explains the high turnover of professionals in this area. Well, the vision